we know that it's safe to exercise all the way through pregnancy and into postpartum, bearing any of those contraindications. But are we prescribing it in a way that is enough to actually see health benefits?
You're listening to the Active Mom Podcast with host Dr. Carrie Pagliano. I'm a mom, physical therapist, and your go-to guide for staying active with pelvic health issues in pregnancy, postpartum, perimenopause, and beyond. Whether you're a fellow mom, physical therapist, or women's health professional, join me where I'll share expert insights, real-life stories, and the latest research to help you approach running, CrossFit, yoga, Pilates, HIIT, or whatever activity you love with confidence and evidence-informed guidance. Let's start the show. All right, welcome back to the Active Mom Podcast. This is a podcast we've been working on scheduling for a long time. How I found our next guest was she popped up in a JOSPT, which is Journal of Sports Medicine Physical Therapy journal, and it was talking about moms. And so anytime you have the word mom pop up in anything other than a pelvic floor journal, it gets my attention. I'm like, who is this person? And I was lucky enough to get to hear her speak and chat with her a little bit at the Female Athlete Conference in Boston in summer 2025. And finally, because she's decided to move cross country, we're finally getting together and talking about her research. So welcome, Jenna Schulz, to the podcast.
Thank you so much for having me. I'm glad we were able to finally make this work.
Exactly. All right. So for people who have no idea who you are, you wear a lot of different hats. So tell us a little bit about kind of who you are, what you're doing, and how you've happened to settle in Vancouver.
Sure. So hi, my name is Jenna. I did the combined physiotherapy PhD program at Western University in London, Ontario. So I did my PhD concurrently with doing physio school. The research that I did in my PhD was heavily focused on knee osteoarthritis and more specifically looking at inflammation after a surgery called high tibial osteotomy. So it was pretty biology heavy, imaging heavy, and biomechanics. Learned a lot during my PhD and really loved, the research side of things. But when I started physio school, I then transitioned more into obviously learning the clinical applicability of research and had a very pelvic heavy placement. And I loved it. And quickly realized that the research in that space was, especially at that time, that was almost 5 years ago now, uh, virtually non-existent. So I was working with my clinical instructor, and I was like, well, how do you know how to guide back to sport, or how do you know what to do? And she was like, this is just based off clinical experience. We have no research. So that kind of switched my um, research interests a little bit heading into my postdoc. I also picked up running in the middle of my PhD because I was a little bit stressed. So I joined the varsity track and cross country teams at Western. So kind of my clinical experience that I was learning through physio school, and we didn't learn a lot about female athlete specific or women's health specific things, combated with the fact that now I was training at an elite level and also working through some health things and not getting a lot of help from some doctors because they didn't really know what was going on or they weren't educated in that sense, made me really realize that there's like really very minimal research on female athletes in general. So then I did 3 years of a postdoc with Dr. Jane Thornton at Western, where we did a whole slew of different work around kind of female athlete health across the lifespan. And I would say pelvic health kind of underlies all of that research that I've done. So I have done some in younger athletes or that varsity level athletes all the way up to some retirement, and that pelvic health kind of underlies all of that because the research that we have in that area is pretty minimal. I'm now at UBC and I'm doing another postdoc, and I'm back in the OA space a little bit, which is kind of fun, but with that female, women, and girl lens. And I still work clinically a couple shifts a week just to kind of keep my toes dipped in the clinical space. Still do see some pelvic patients as well as just active patients, which is kind of a nice way to balance the research and the clinical work.
Yeah, so you're a research junkie who we can't get out of the clinic, which is my favorite. It's my favorite. And I love that we brought you over to the dark side of pelvic. I think every good orthopedic PT ends up there, I think.
Yeah.
So that's awesome. No, one of the threads that I kind of saw going through a lot of your work is kind of talking about activity levels, cardiorespiratory fitness, that sort of thing. And as much as we've seen conversations grow, and I was chuckling, you're like, oh, there wasn't anything 5 years ago. I'm like, yeah, we've been hit really hard in a good way with the amount of research, especially out of Canada. You guys are killing it. Thank you. Um, we don't talk a lot about those sorts of things, like general. I think we're getting more about like athletes and running and lifting and things like that, but just how do we get a sense of what cardiorespiratory fitness actually is? What does that look in pregnancy, postpartum, and so on? And kind of where do you start from a research perspective? So maybe you can kind of talk to us a little bit about kind of that aspect of what you studied.
Yeah, so I think again, we've been inundated with more and more research, which is awesome. We still need way more. I know Margie Davenport's doing phenomenal work. She's really leading this entire space.
Yeah.
But the systematic review that I wanted to look at, I did a similar one in NEOA actually, and I wanted to kind of mimic it in this population. And I really wanted to look at, okay, well, we are people actually exercising enough in postpartum to see improvements in their cardiorespiratory fitness or improvements in yeah um, their VO2 max, things like that, because we know that it's safe to exercise all the way through pregnancy and into postpartum bearing any of those contraindications. But are we prescribing it in a way that is enough to actually see health benefits? Um, and so that was kind of why I wanted to look at that piece, because it's great that we now know that it's safe.
Hmm.
Awesome. Phenomenal. Everyone exercise. That's fantastic. And some exercise is better than none. Absolutely. And we know that. But there is that dose response. So the more that you exercise, the better the benefits are. And so I wanted to see if that story was similar in a postpartum population. Unsurprisingly, it is. And with the research that we found, there was some small benefits, like some small improvements in cardiorespiratory fitness, but not substantial and not massive. So that just tells us that as researchers, when we're researching this, we're not actually prescribing exercise at a high enough intensity. And as that can be kind of switched clinically, so obviously when someone is 6 weeks, you're not going to say, okay, now go run 150 minutes per week. That is
Right.
valid. But how do we actually prescribe that exercise in a way that is meaningful to the patient and
Hmm.
also can elicit these changes? And again, it's all about working with the patient that you have in front of you. If you have someone that didn't exercise during pregnancy, you're not going to go say, okay, well, now go 150 minutes a week, please go meet
Right.
this. Um, but I think that that should still be our goal, to try to get people up to that level, because we know just the benefits of being physically active, and not only for your physical health, but for things like postpartum depression and uh, all those other mental health aspects that are a big factor in postpartum.
Yeah. And I dare say too, and this is kind of what I'm curious with your clinician hat on. Um, Fully understanding that this is the Active Mom podcast, we're making a lot of assumptions, at least that women are active even going into pregnancy, and then there's still that myth, rumor, whatever you want to call it, things that people are told when they hop on the pregnancy conveyor belt. Oh, well, you shouldn't start anything new in pregnancy, which we know actually no, like if you're not exercising, this is a great time to start. Maybe not like
Mhm.
start doing kickboxing, but like start doing something. With your clinician hat on, what can we do better? When can we start those conversations? How can we encourage um being better about prescribing exercise? Because literally as physios, this is kind of supposed to be our jam, right?
Mhm. Yeah, and I think again, it's all about the person that you have in front of you. But just like anything, like for NEOA, like I said, I did a very similar study. Just the population was very different, but the story is the same. The earlier you can start this, the better. The earlier that you can get someone in the habit of exercising, the better. And
Yeah.
again, it's not about saying, okay, like we know that 150 minutes a week is what your goal is, but that doesn't mean that you jump to that right away. It's saying, can you think about doing a little 10-minute walk in the morning and a 10-minute walk in the afternoon as a start?
Yeah.
Or can you get up every hour and do some stretches or some jumping jacks or something and getting in those movement breaks? I find that is helpful, especially in this population because obviously they're so busy. They may have another kid at home. Now all of a sudden they're taking care of two kids. Their sleep is probably non-existent. They probably aren't eating as well either. So then asking them to say, "Okay, well, you're not able to fuel as well, or you're not sleeping, you're probably not recovering, but I still want you to go out and run 30 minutes a day." Is probably not realistic. But instead trying to think about those like movement snacks.
Mhm.
So like, can you take a 10-minute break and can you do a quick 10-minute workout somewhere? Like
Yeah.
things like Peloton or like the Nike Fitness app has those like really quick
Yep.
10-minute workouts. So that is kind of how I start trying. And that is way more feasible than saying go out and run for half an
Yeah.
hour every day,
No, totally.
especially if they haven't never done that before. That hasn't been
Right.
like if running isn't important to them and they don't enjoy it,
Right.
then I'm not gonna tell them to go run all of a sudden now postpartum or early pregnancy because they're not gonna enjoy
Yeah.
that and it's not gonna happen. So you have to find what obviously works for
Yeah.
the person that you have in front of you.
Yeah, no, it's funny. Sometimes I have women that come in, and almost one of the first things that they do is they apologize. They're like, "Well, I run a little bit, but I'm not a runner," and they almost like apologize. And I'm like, "No, if you're moving, that's great. That's a start." But again, I do think you're right. Digging deeper into what that means for that person. What did this look like before? I mean, I had a client yesterday. She's her second is like 8 months old, um, and very, very, very active. She brought her in. She's so stinking adorable, but they don't stop moving.
Yeah.
And I needed her to do a couple exercises. I'm like, you know what? I'm not going to give you specific things. I'm going to give you concepts. And we needed to do rotation. And so we literally laid on the floor in my clinic with her 7, 8 month old. And I was like, all right, how can we make her fly? How can we do movements? Because that was going to be the only way it was going to get done. And I was like, all
Mhm.
right, bottom rotates, top rotates, like, okay, we can do this lying down, we can do this all fours, we can do this standing. What are all the things? And I'm like, just rotate, hold baby, make her laugh. That's your workout. And I was like, but I think, that it almost sounds ridiculous to somebody where you're like, no, you need to teach them, these particular I'm like, no, 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 it can look like so many things. We don't want to put up that barrier that exercise has to be, this prescriptive. And I think this was screwed me in my first postpartum. Was I had this idea that if I didn't have that perfect 30 to 40 minutes to do it, I wasn't going to do it. When you have a kid that doesn't nap, that doesn't happen.
Yeah.
Yeah. Oh my gosh.
For sure, and I think that's really important, and I think on the like, there's almost like 2 sides of this study, is
Yeah.
that it makes sense that they're not really reaching that 150 minutes per week, but also this is a research side of things, so from a research perspective, we should try to encourage that, but also I think we need to not be scared to underdose or to overdose, because
Yeah.
I think it really depends on the person that you have in front of you. Everyone's going to be different, but if you had someone who was running 6 days a week all the way up until week 36 or 38, and, obviously they're gonna take a little bit of some rest, you're gonna build some foundational strength, you're gonna get back into some things, but if they can make running work and they
Right.
have the support at home that they can leave the baby for a little bit, or they're gonna run with the baby because one of those
Mm-hmm.
moms with the stroller that is running like crazy, or you have like a pretty high level elite athlete where that's their job. So
Right.
obviously they want to get back to it because they want to get back competing.
Mm-hmm.
Then I think the flip side is okay, well, clearly they can do this. Like
Mm-hmm.
they probably exceeded 150 minutes a week
Totally.
all through pregnancy. Well, before pregnancy, absolutely. So we shouldn't be scared of like, okay, you can't actually do that much. Again, if they have symptoms,
Mhm.
it's a different story. It's about working through if they are having pelvic floor symptoms, or if they're
Right.
not eating and sleeping and they're breastfeeding and they're in that energy deficient state. That's a different story. But if someone is doing well, I think there's no
Right.
reason why we can't actually push that
Yeah.
limit.
That's a conversation I've been having more lately. I'm glad you mentioned that. We just had Sophie Carter on the podcast this past fall. She had shared some of her Garmin data running in her, what was her third and fourth or fourth or fifth? It was a twin pregnancy and then a singleton pregnancy. She did ultras and raced them all the way through. And first of all, like, I can see people being like, "Oh, that's too much." And I feel like we've gotten a little bit past that now that, like, it's normal to see people who are pregnant working out. I think generally I will speak to North America as a society, we're cool with that. But yet I still see in Facebook groups, people are like, "Okay, well, what should I plan for in postpartum?" And I feel like some of the guidance has almost been weaponized, and it's like, you can't do anything till 12 weeks. And I
Mhm.
think our field, or at least here in the States, like, I think we're guilty of, facilitating a little bit of deconditioning there too. And I'm like, well, it depends on so many things. It's a very nuanced conversation. What were you doing before? What did your delivery look like? What does your support system look like? Are you sleeping? Are you eating? Is your baby eating? Like, there's so many parts and pieces, but we can my experience and your experience can both be held at the same time. Neither one is right or wrong, but let's just be honest. I was never going to run as fast as Sophie Carter when she's running in her, fifth baby, third trimester on my best day. On my best day. I will never be Sophie Carter. So, do you think that's a really hard thing for people to wrap their head around is nuance and just the broad expanse of understanding of what postpartum can look like? Is that the problem is that we don't have the capacity or that we've been taught that it should be this thing and anything other than that is going to blow people's minds?
Yeah, I think it's a little bit of both. Like, I will say that in physio school, we had like, which is okay. It's a 2-year program. It's quick. They got to cram everything into us. We have to learn cardio rest and we have to learn neuro and we have to learn MSK. But still, we had 3 lectures on women's like pelvic health.
You
Um,
had more than I did.
Yeah. So it's good, it's getting there. And I do get that there's a potential like, some people will argue that that's a little bit more advanced healthcare practice, but in my sense, like, you are going to encounter someone in your clinic that has had a kid. It doesn't mean that they're necessarily coming to see you for that. However, you will encounter this at some point in your clinical life,
Yep.
probably very early on because it's, you know, a lot of people have kids.
Yes.
Um, so I do think that there is a responsibility for everyone to at least like learn a little bit and understand how you can help someone progress through and understand when to refer out. I do think that, yeah, I think that, it's great we have all this research, but I do think now it has flipped a little bit and it's like you have to wait 6 weeks or you need that clearance before you can start everything. And even like my thoughts on this has changed too, just going through and working more in the clinic. I think when
Hmm.
I first started, I was like, "Oh yeah, they should be cleared." Like that,
Hmm.
why wouldn't they? But then I'm like, "But that's actually a barrier." And
Right.
Margie wrote a really good paper on that too,
Yep.
that's actually a barrier is that you need to have like a true clearance before you can start sport. If
Hmm.
you have your kid and you're feeling okay day 3 and you wanna do some yoga, go for it. Or you wanna go for some
Hmm.
walks, that's totally fine.
Yeah.
Again, we just based off of the symptoms. So I think it's more that we need to educate our clinicians and these moms that, some movement isn't
Right.
bad. Movement is actually going to help you. So yeah, you don't need to wait 6 weeks before you do anything.
Hmm.
Do you want everything to heal? Absolutely. If you have a C-section, a little bit of a different story.
Hmm.
You Your body has undergone a trauma, it does need to heal, but everyone's gonna heal differently,
Hmm.
and it's the same thing, like, you tear your ACL, well, we don't immobilize people for 6 weeks anymore. We don't put
Right.
them in a brace and say, tough. See
Yeah.
ya," right? Like, we start things right away. It's gentle, but
Yep.
it's something.
Yep.
Or if you even if you have like a stress fracture now, it used to be let's hard cast those. Okay, well, we don't even really put them in boots anymore. And when
Right.
I have a runner with a stress fracture, they're still biking usually, and they're still swimming as long as
Hmm.
it's not painful. So I think that that narrative should probably shift a little bit, but
Hmm.
I think the hard part is it's so individualized, so we can't
Yeah.
come up with like a blanket
Right.
guideline.
Well, even, I mean, I feel like even from how I will handle a first time mom versus a mom who's got a couple of kids or even just one at home is so different. And my experience was so different. I mean, I had two C's, but the second time I had to go home and I had a 2.5-year-old who could care less what I just did. And I just wanted to get on my way. I was like, let's get going here. And so I find that first time moms are definitely, I don't know, gosh, it depends. Again, it depends. Like I have some that if they have issues, they're so scared to do anything or they want to be super prescriptive. And then they have others that where I see this theme of wanting to prove something to themselves or to others or whatever. And so, but I find that I handle them much more differently. Second time mom, and the ones who I love, and I've said this a million times before, are the ones who've had like 4 or 5 kids, are like, they're not going to die. They'll raise themselves. I'm going to the gym.
Yeah.
It's
Yeah,
like, you go.
exactly.
I wish
Yeah.
I had that confidence. But yeah, to your point, like it totally depends, but we have to normalize that conversation of, gosh, don't play comparison game with your friend down the street. Don't judge. We have no idea, and I tell moms that they come in and they're like, yeah, my baby's sleeping great. I'm like, don't tell other people that.
Yeah.
As a mom who my oldest did not sleep the first 5 years of his life, I'm like, don't tell me that.
Yeah.
But yeah, it's so nuanced. I don't think we do well with nuance. I think we do well with tell me exactly how this is supposed to go, and I will tell you whether my experience is bad or good, you know?
Yeah.
Um,
And I think that's the hard part, and again, I'm
yeah,
gonna continue to use the ACL as the example because I also see a lot of knees. But, with our ACL, we have our very, like, prescriptive return to
right,
sport guidelines. Again, it changes depending on the person that you have in front of you for sure, what their goals are, what they're wanting to get back to, what they look like pre-surgery, all of those things. But in general, it's pretty much like, you start with range of motion and then you start,
right.
like, so, and you follow this guideline and you go through and
Yep,
at potentially 6 months or whatever, if they're strong enough and they have enough strength, then you start adding in some hopping and some running. And then
yep,
at the 8 months, you start doing a little bit of some specific sport
right.
exercises. So it's very prescriptive,
Yeah.
but we don't have that in postpartum. And again, I think I've changed my view on this a little bit. And I don't actually know if we can make that. I think
Mm.
that again, we could have like a general guideline, and I think that
Mhm.
that general guideline needs to be rooted in evidence, and I think it will be. Um,
Yeah.
and
Well, I'll
I'll
pull
be
this up that was
yeah,
in BJSM. Yeah, I was like, "Ooh, perfect timing. Way to go."
yeah. So I think that something like this, or like a general guideline that is again very rooted in evidence, is helpful, and this can be used to help guide, but I don't think we can have like a specific return to sport protocol like we
Yeah.
do for Achilles or like we do for ACL,
Yep.
because I think there's way too much nuance
Yep, I agree.
that goes into this because everyone is so different. So I think
Yeah.
have it, yeah. So this was something that we did for BJSM after we did a scoping review looking at return to sport guidelines. Again, we found like none really in the literature, nothing really specific. So
Right.
instead of writing up something again that had like specific timelines, because I don't think we can focus on timelines, we thought about just saying, okay, looking at it kind of like an MSK injury, what are your steps
Mhm.
to returning to sport after postpartum, and what sort of things could you potentially work on? And this could help guide clinicians to say, okay, these are my steps, but everything in between is going to look very different. So
Yeah.
starting with,
Yeah, I
sorry,
was
go.
gonna say for people that aren't watching on YouTube that are just listening, can you kind of talk through where this is an infographic that was in BJSM in 2024, and BJSM does an amazing job with infographics. Whoever the person is that helps come up with this stuff is chef's kiss, amazing. But yeah, talk us through kind of what these steps are.
Yeah, so it starts with return to activity. And again, depending on the person, depending on the mode of delivery, depending on any contraindications, this could probably start right away. These are things like pelvic floor exercises. So, if you were seeing a pelvic floor PT all the way through pregnancy, getting a check in like pretty early on, if even virtually, I found that was really helpful with
Mhm.
the one placement I was on, is having a virtual check-in within the first 2 weeks. So then you can still stay at home, but we can check and just see how things are going along. And then walking. The next step would be more exercise. So that's starting some body weight strength, progressing to some weights, working on all major muscle groups. Now again, if your sport is running, you're probably going to focus a little bit more on lower extremity. You should still work your upper extremity. Um, or a different sport, you're going to maybe focus on something else, but just trying to hit all major muscle groups with some exercise. And then potentially low impact cardio could begin in this stage too. So, again, things like cycling, swimming, depending how things are healing. The next step would be participation. So this is when you're going to start more functional exercises, more activity specific exercises. So if that's, let's say, soccer, for example, then you're probably going to start a little bit of some dribbling maybe in this stage, or a little bit of some like cutting and pivoting, because you obviously need to do that when you're playing soccer. Progressing the aerobic as well. So always progressing the duration over intensity. And this is something I do with all my runners, regardless of their injury, is before you do a hard workout where you're going at your 5K pace or you're going at your even half marathon pace. I want you to be able to run for an hour and tolerate an hour of running first before we bring the speed in. So I think the same thing can be said here. Um, if someone is wanting to get back into training for a marathon and they are used to doing those types of workouts where they're not just going out and running,
Right.
but you want to be able to progress how long you can run first before how fast. And then plyometrics are also really helpful for a pelvic floor. Gives you a good sense of whether or not you're ready to do something like run, jump, twist, pivot, all those things. So that would be in that participation. Some people are happy, and that's kind of the end stage for them, and that's
Mhm.
great. But if someone is wanting to get back into more, they have a specific sport or, some sort of competition that they want to get back to, then we'd keep going. So that
Mhm.
next stage would be return to sport. So that's when you have those really sport specific training. Someone can probably start getting back into some practices now
Mhm.
if they have the ability, if they're, on a team that they practice a couple times a week, starting to get back into practices. And then finally, that last stage is that return to competition. So being both mentally and physically ready and kind of follow up as needed at that point. I think, too, it's important to highlight that at any stage, it's okay if you have to take a step back. It
Mhm.
doesn't mean that you've lost all your progress because you had a bit of a flare up in your pelvic floor symptoms, or it doesn't mean that you are doing something wrong. It just means that potentially you weren't 100% ready to get to that next stage, and that's okay. So
Yeah.
taking a step back, knowing that we know that rehab is never linear, unfortunately. Progress is never linear, and I think this is a similar story.
Yeah.
And
No,
then I
I
think,
love Go
yeah,
ahead.
I was just gonna say, I think throughout the whole process, it's important to screen for other things such as relative energy deficiency in sport. Again, we kind of chatted about it, but you know, if you're trying to get back into high level exercise and you're also not sleeping and you're also not eating and you're
Mhm.
not recovering and you're breastfeeding, so you're expending way more calories than you were before, it's that's an important thing to consider. So monitoring things like energy levels, sleep, nutrition, um, and also, if they have any sort of pelvic floor symptoms along here, you're going to want to take a step back and say, okay, how can we rehab that? How can
Yeah.
we work on that? Um, and yeah, just knowing, like, having a group of people in your corner that you can refer your your athletes to. So
Yeah.
a dietitian can be really helpful, pelvic floor physio, maybe sport med, um, and kind of working as a team to help progress this athlete through this stage.
Yeah.
This, yeah.
I love this for a couple reasons. Number one, there's no dates on it. There's no this many weeks, this many time, because like we've been discussing, like it's so different with everybody. With this kind of framework, I feel like I can apply it to, somebody they ran through pregnancy, no issues, they're ready to get back early postpartum. They know what those red flags are. They're going to watch out for them. We're going to progress them back and see, does a critical threshold ever show up where they start to become symptomatic, or are we good? But I can also take this forward to the mom that maybe they were stuck in return to activity till their kids were like out of elementary school
Mhm.
and just really didn't have time or desire or anything. And essentially, we're going into maybe those perimenopausal, menopausal years. They never really got back. And I'm seeing a lot of these women right now, they're very much my vintage, where they're like, well, I didn't do pelvic floor PT. And I'm like, that's okay, because we were here, but we weren't like, people didn't know about it. So we're going to go back and get you caught back up, but you can still follow this progression. It's like, still do the baseline, still get you back to, mom that wants to do, I know you guys just had your Thanksgiving. I was up in Vancouver for that, but ours is coming out soon. Mom that wants to do, the turkey trot, or mom that wants to do, the school's 5K with their kid or something like that, and doesn't want to just, walk it. I think having a framework like this that isn't necessarily like, okay, if you didn't start it now, too bad. Like a lot of moms now are looking back and being like, well, I didn't really have a pathway forward. I want to do that now. What does that look like? And it's still the same framework. And that's what I love about this so much, is it allows some flexibility. And it's, again, it's not a barrier. It's the opposite of that.
Yeah, absolutely. And I think that's why we wanted to kind of make an infographic to go along with some of the research, because yeah, we don't like, physical activity shouldn't be a barrier. It should
Right.
be easily accessible for everyone, but people just don't know where to start usually.
Yep.
And that's okay. That's tough, but that's where our job comes in. And that's
Yeah.
where, as researchers, we need to do a better job of getting our research out there, because not everyone can access these things.
Yeah.
As clinicians, we need to do a better job of just educating our patients and working with them about, okay, what can we do? What can we work on? What can you start right away?
Yeah.
Um, and yeah, just not being so heavily fixated on a specific timeline, or heavily fixated on a specific, like I said, like a protocol for an ACL is very like didactic, and you go through it. And
Right.
I don't think we can take that exact framework and
Yeah.
apply it to this population. And I think that's why there hasn't been much guidelines up until this point. However, I do think that we can make general recommendations. And I do think that we do need to develop some sort of guideline that is very like rooted in evidence. There's not much evidence out there to support it. Um, but I think that it's going to look different from all of our other return to sport, and should look different from all of our other return to sport guidelines in
Yeah.
this population.
And that's honestly, so a full credit to all of you, that especially the ones that are like straddling research and clinical conversations, because, Lord knows we need more of you. Um, it's funny, I look at this infographic and my initial gut sense is like, "Ugh." And it's that because I'm like, well, I know that, but I forget that, like, having some sort of overarching view of like, yes, there is a progression to this, is not necessarily the first thought of the average postpartum mom. And that's where I kind of have to stop and check myself and be like, yes, but this is new for that person that just had a baby. And what does this look like? And they're not relating coming back from having a baby with coming back from, an injury or this or that or whatever, like anything that's even remotely similar. You cannot compare coming back to an injury from having a baby. We're just going to be clear about that. But at least in the same kind of like hemisphere, I suppose, that it's a progression. It's not a all or nothing sort of thing. So in my sour old age here, I've become much more appreciative of how much work is behind something that's so exquisitely simple as a framework like that.
Yeah.
That all of the mush has been distilled into this beautiful little infographic, so I appreciate it a lot more. Um, to move on a little bit, you've had a couple papers come out this year looking at the FAIR consensus, which is a little bit different genre than talking about postpartum. Tell us what the FAIR consensus is. Tell us how you got involved in it, some of the heavy hitters who are involved in that as well, and what that means for women.
Yeah, so it's been a really awesome experience. It's been 2 years, I think. Yep, we started in 2023. So this consensus is the female, women, and girl athlete injury prevention consensus. That's where FAIR comes from. The R is from the R in prevention. And it is being led by doctors Carolyn Emery and Kate Crossley, who are two of the biggest sport med researchers, if not the biggest sport med researchers globally. Um, both phenomenal women. It's been great to get to know them and work with them. Um, and so basically, what we did is a consensus statement looking at injury prevention and risk factors for female, women, and girl athletes. Um, it started in We started our review in October of 2023. So I was brought on to, there are 7 reviews that are informing the consensus. I was brought on to one of them, and it was we called it the Spine Plus review, but it was any sort of injury related to spine, abdominal, and pelvic, which is where I came in from the pelvic side of things. So we ran our search in October. Um, we pulled all that information together. We screened through all those articles, and then we ended up um, with, I think it was 100 and something papers at the end. I don't remember off the top of my head. This is just one of the reviews. And then we specifically looked at, okay, are there any exercise or prevention interventions or risk factors for female, women, and girls specifically? Um, and we didn't have enough evidence to synthesize anything for exercise for interventions. There were a couple exercise prevention interventions for low back pain. The rest of the other risk factors were all for low back pain, so nothing pelvic related. Um, and again, they basically was saying that there's not enough information. So um, that's just the one. The story is very similar across all 7. Well, I guess there's 4 other reviews on body parts. So upper extremity, lower extremity concussion. Um, some of them have a couple where we know that something is protective.
Hmm.
We know that neuromuscular training programs work for ACL
Hmm.
protection for ACL injury. So some of those things we know, but in general, number one, there's like no out of the I can't remember the stat. I think it was out of the maybe 100,000 athletes that
Oh
were
God.
included over all the reviews, or close to that. It's like 16 or 17% were female, women, and girls in all of these studies. So
Hmm.
that in of itself is like a massive finding. Um, yeah, just not enough information
Yeah.
to really make conclusions that those injury prevention or those risk factors that are in males and men are the same in female
Translatable. Yeah.
and translatable, because we just don't have that evidence
Right.
out there. I'm going to see if I can pull up the full numbers. Um, but the actual consensus is going to be published within the next couple of days, I think. So,
Oh,
well,
nice. Okay. Well,
well,
it should be by now. By the time this comes out, it should be published. Go check it out.
be out there.
But you,
So then we came together then. So we all did these reviews. Yeah, I've just pulled up the spine ones now, and we were out of the 59,000 participants, 23% were female, women, and girls.
yeah,
We were able to pool some data together, but the studies themselves weren't super high quality.
yeah.
But there was really no, the very low certainty, so we're not certain, and the evidence suggests no difference in body mass, weekly training hours, or spinal flexion
Yeah.
between girls with or without, female women and girls with or without low back pain. Yeah. So again, pretty inconclusive research.
Yeah.
So then we had 5 of these different reviews. We also did one on implementation, and
Mm,
then there's another one on um, a concept mapping study,
mhm.
which was kind of cool. Then we all went to Lausanne, so it was really awesome. So I got to go to Lausanne with the steering committee, um, with all these big names in sport med, which was super cool to
Dream. And
just
then you
be.
got to run there too, didn't you?
Yes, and then I went on
Oh,
really nice runs, some mountain runs. We were busy days. We had meetings from like 7:30 a.m. until 7 p.m. and then went for dinner and then would go back and have to update our surveys.
oh wow.
So we were doing work till about midnight and we'd get up and kind of do the same thing. But um, then basically we all get into this room and we are trying to develop recommendations.
Yeah.
And these recommendations should be out. Um, and so we vote on them, and then we kind of take them, we update the surveys, we bring them back again, we vote on them and keep going. But as we're voting, we also are discussing them within this large group.
Mhm.
So that's how a consensus process works. It is like a 2-year process for
Yeah.
sure, but it was super cool to be a part of it. Um, and I'm really excited that, well, yeah, it's out. And I mean, like, kudos to Kay and Carolyn and Jackie and Jane and everyone who has been a part
Yeah.
of this, because was a massive, massive undertaking.
Yeah.
Um, and yeah, I'm just lucky to have had a seat at this table and watch this consensus process and learn from it, but also be able to contribute it, which was
Yeah.
really cool. So we also wrote an editorial about.
Yes.
So
Where are all
Jack,
the female women and girl
yeah.
athletes?
So
Tell
that
us about that. Like, I mean, because, and I would love your opinion with your clinician hat on as well of like, okay, this was an amazing research experience. You're with all these research goddesses. Like, now how do you step back and kind of navigate this information as a clinician and as the average person?
Yeah, and it's a lot of information for sure, and that it's overwhelming, um, and I absolutely, like, even, if I were to pick it up on a clinic, you're sitting in the clinic and you're busy, and all of a sudden you have this paper that has like 7 reviews and 7 editorials. So that was part of the reason of writing the editorials, is because
Hmm.
that kind of disseminates the information in a more digestible manner. But I
Hmm.
think the biggest thing and the biggest take home as clinicians is that we can't take, or at this stage, we don't know. It's not that we can't, we don't know if those prevention interventions that have been developed and tested in males and men can be explicitly transferred to females and women. And
Hmm.
so, from a research standpoint, we have a massive job, as we need to do much better at disaggregating our data. So
Hmm.
if you are having both in your study, that's fine, but separate the data.
Hmm.
We need to be better at recruiting female women and girls in general. We need to be better at studying, and I think we're slowly getting there because there has been this boom, but studying things that are specific to female women and girl athletes.
Hmm.
And if we can do that as a research, then I think that it makes the clinician's job a little bit easier,
Hmm.
because it's like, okay, here's what we know. Here
Hmm.
is what can and doesn't work, or
Yeah.
what we have evidence for working in this population. Um, I think being a clinician is hard because the research is changing all the time, and you have to
Hmm.
keep up with it. And if you don't, then you kind of get left behind. But
Hmm.
that going into being a physio, that's your job is to be evidence informed. But I think that from research standpoint, we need to do a better job of making it easier for the clinicians to digest and understand this information.
Yeah.
And so that's one of the big things that we're continuing to work on with this consensus, is how can we disseminate this information
Hmm.
to the people that matter, so to those end users of sport, the athletes, the coaches, the parents, the other practitioners,
Hmm.
physios. ATs. How can we disseminate this information in a way that it's actually going to be meaningful?
Yeah.
And how do we disseminate all of our future research in a way that's actually going to be meaningful for this population?
Hmm. Yeah. No, I think um, I can definitely speak to, at least here in the States, I think how we communicate data and information is it's an imperative skill. I mean that's actually one of the reasons for this podcast is there are some people that are really gifted to be able to do research, to be able to provide a platform for them to put it in their own words instead of somebody explaining it for them and potentially getting it wrong, because we know that happens and they use it in ways that it was not meant to be used.
Yeah.
But then again, like how do you be able to speak the language where you can understand, and my brain isn't as good as this as I wish it were, is like how do you wrap your head around all the nuance of, the logistics and the mechanical aspects of how research is done and what makes something good quality evidence versus something else, and then pull it into a context in which it makes a difference for that evidence informed provider, and then dilute it but not lose the essence of it, to be able to translate it to that person that's sitting in front of you, and not lose anything, but if anything make it more powerful and valuable because we're actually able to implement it. Like that's the dream, right? Like
Yeah. And I think that's why I love sitting in both spaces. And that's
yeah.
I think that, you know, being a clinician makes me a better researcher because it makes me think like, okay, but who cares?
Yep.
Like, really, who's going to read this? Who cares? How can we make this so that it's not
Yeah.
just who cares? Can we make an infographic? Can
Hmm.
I do something? Can I even just like present this work to the clinic that I'm at?
Right.
Do I make it easier for them?
Right.
Because then they don't have to shift through and sit down, and some of them will because they want to, but even then, sometimes, yeah, it can be hard to understand what does
Hmm.
it mean when you say low certainty evidence? Like, I don't understand that.
Right. Right.
Or, okay, so you just pulled a bunch of studies together, like, how did you do that? Or how did you come
Hmm.
up with these recommendations? Like, that can be difficult to understand.
Right.
So, that's why I like having both hats on because
Yeah.
definitely being in the clinic makes me a better researcher.
Yeah.
Because of the research, it makes me a better clinician because it's like, well, how do I actually apply that? So I think
Right.
we're slowly moving away from, and it'll take time, but just like what makes you a good researcher is your metrics. How many times do your papers get cited? How many times are you publishing in the biggest journals? All of
Yeah.
those things. But I think more and more it's okay, well, that's great, but what is the evidence that your research is actually being used
Hmm.
in practice? So that's where we as researchers have a, you know, it's not just about doing the research anymore. It's about how can
Right.
you actually change practice, and that's hard
Hmm.
to do. But that's where
Yeah.
things like editorials and infographics, and then there's the whole paywall thing, which we don't even get into. um, Giving talks
Yep.
and talks not just at research conferences, but things like podcasts, things like
Yep.
these, which are so much more digestible for some people.
Yeah.
They can put this on while they're driving or
Yep.
on a walk or
Yep.
versus just having to sit and read something. And that's where that is how we need to get that research out in a way that is digestible
Hmm.
for everyone. And it is not easy and it'll
No.
take some time to change, I think, but
Yeah.
there is more and more focus on that piece versus just like, what is your H index? How many citations
Publish or
do you
perish.
have?
Yeah.
Yeah,
Yeah.
publish or perish. So
Yeah.
it is nice to see that shift happening, but it'll take some.
Yeah. Well, and on the other side of the coin though, I think in this day and age where people are trying to find or adapt research headlines to fit their biases, it's really hard as a consumer when you see, a large medical influencer talk about breaking news and come to find out it's like, you know, from a press release from a poster that hasn't even been published yet. And yes, that's an exact thing that happened 3 weeks ago in October. And like, no, that's actually, and if we dive into that, it's like, okay, there's a lot of other nuance, and and then we've got to go back to the researcher and be like, okay, what did you actually say? Because that's not what was said. And so I think there's responsibilities on both sides of like, how do we make sure that we don't abuse the information? How do we make sure that we get it right? And if it doesn't fit our biases or our narrative or the thing that we're selling, because let's be honest, that's what a lot of people use it for. How do we make sure that we're adapting and evolving ourselves when we're on the other side of this? If research is telling us, hey, what you're saying isn't right, it isn't about my ego. It's about my ability to adapt and get the information to the right information to the right people using the platform that we have. So there's a lot. That could be a whole other podcast.
Yeah. Yeah.
Whole other podcast. So
Yeah, I agree. And
yeah.
I think definitely, like, that again, that's why I like being both, because I just, like, feel like I take
Yeah.
responsibility for both ends, but,
Yep.
there's an onus on us as researchers to make it more digestible and
Yeah.
translatable and easier to access and easier to understand, but there's also
Hmm.
an onus on me as a clinician to take the time
Yeah.
to read those things that are
Yeah.
a little bit more digestible if I don't have the
Yep.
time, or
Yeah.
and also to be able to put on a hat and a critical thinking hat and
Hmm.
say, yeah, this doesn't really
Yeah.
make sense to me. I don't know
Yep.
if this really works. Um, and saying and being able to put on that hat and say, okay, but how can I put this into my own practice?
Yeah. Yeah.
And we do make some of those, obviously, as research, we try to make some of those recommendations. But again, yeah, everyone's practice is different too. So
Yeah.
we can't make these recommendations that says that you need to do this when not like people
Right.
practice differently. So
Yep.
um, yeah, lots of work to be done, and
Yeah.
the dissemination and implementation science I think is really cool.
Yeah.
And I'm starting to learn a little bit more about some of that stuff, which is
Yeah.
awesome. And trying to dip my toes a little bit into some of that work, because I think
Yeah.
that if we don't understand why these things aren't being put into practice,
Right.
we're not going to be able to change
Yeah.
practice with our research, which, we spend hours in 2 years doing these things, or
Right. That's what you want to do, right? Like,
and it is
right.
important work. It is super
Yeah.
important. But again, if we can't get it into the hands of the people that are
Yeah.
going to use it, or
Yep.
if there's some sort of barrier there that we don't understand as to
Hmm.
why it's not getting in, like I think the
Yep.
stat is research to change clinical practice is 10 years.
Mm.
That's usually how long it takes for something in research to actually change clinical
Oh,
outcomes.
I thought it was 20. You're
Oh,
shaving off
oh,
the you're shaving off.
10. That sounds
I don't,
nice.
we'll go in between 15.
Uh,
Let's make a deal.
so, like that doesn't,
Yeah.
that's useless.
Yeah, that's not either way,
Yeah,
it's not good. It's
yeah.
neither number is good. Yeah, yeah. No,
So,
yeah.
yeah,
I appreciate in all of this, and I think this is one of the things that I've learned doing this podcast now. I think I don't know for 3 or 4 years, I can't count anymore. Is just humanizing the research. Is that there is a person behind this. There is a story behind you. There's a reason why you started down these roads in the first place, and your brain works a certain way, so you can look at this problem in a way that maybe I can't and perceive this. And so that's been such a gift to be able to humanize this and put a face and a voice, because for so long it was just like a name on a page and you're terrified of who that person is because oh my gosh, they got their PhD and 17 postdocs and all this stuff. My personal favorite though is usually the people who are not clinician researchers, the ones that are just researcher will always ask me for the questions first
that's
that I'm
funny.
going to ask, and I'm like, I don't know what I'm going to ask. So I've decided to just be like, I'll just make something up, and whether we ask it or not, it doesn't matter. But I'm like, no, no,
Yeah,
no. I see you need to know what this is, but I trust me. As soon as I warm you up, it's all going to be fine. It's going to be a
yeah,
great conversation. People are going to love your work. It's going to connect, and I think that's for me has been such a gift. Is we're all humans in this. We're all trying to do better.
yeah,
Researchers just have this amazing way that their brain works that mine will never be. But how can we take that and move all that stuff forward, which is super fun. So.
yeah.
All right, at the end of every episode, we have a couple of questions. I might add some new ones in there. So for you, book or podcast that you're listening to right now?
Oh, that's a great question. In my move, have not done a whole lot of reading for
That's
fun.
okay.
So the last, oh, yeah, I tend to because I read so much research,
Mhm.
and I also I'm all or nothing. So when I start a book, it's all I do.
Okay.
Start this book and don't do anything else, which is bad because I have all this other work to do. So I have not read a book for fun recently.
Okay.
However, my mom bought me for my move like a book that has like just a bunch of like quotes, and they're like some motivational and some just like stupid little quotes. And so
Nice.
every day when I'm having like a not so great day, I flip it open and try to
Okay.
find a quote. So that's probably it right now.
Okay.
Not a great
Um,
answer.
do you run with headphones? And if so, what do you listen to?
I do. Um, Depending on the run, if I'm doing like a workout, I won't, but
Mhm.
just an easy run, I will. I have the same probably 3 rotating playlists, again, because I am a creature of habit. Um, One of them is like today's top hits.
Okay.
One of them is like an 80s playlist.
Oh, yeah.
Yep. And one of them is like a 90s, early 2000s playlist.
Okay. All
Yeah.
right. I see you.
Yeah.
Favorite place to run in Vancouver so far?
Oh, that's a good question. Yeah, I run on the seawall almost every day. It's beautiful and I have not gotten sick of it yet. However, I have done a couple runs up in North Van along like Fisherman's Trail, which is just like beside the Seymour River, and it is beautiful. There's the mountains and the water and the trees, and I did a trail run over there too. So I'll have to say North Van for now, but
Okay.
I'm looking forward to exploring more places.
Awesome. Yeah, I had no idea what Stanley Park was, and I
Oh,
saw a
Stanley
couple of
Park's
your
beautiful.
pictures. Yes. And I
Yes.
did whatever, I don't know, my hotel had something like, do this. This is a popular run. It was like 7.5 miles from my hotel over to Stanley Park across the center. So you're in like the old growth
Mhm.
forest and then over to the beach and then kind of around and back. And I was like, this is kind of amazing. I'm totally into tourist running now. So
Yeah, that's like my favorite thing
yeah,
to do when I'm
yep.
traveling is to go for a run. I
That
love
that's become my new favorite thing.
Yeah,
Huge fan of it. And then favorite new food since you have gotten to Vancouver. What's I should have asked you all these like a month ago.
I know.
But like what's your favorite thing that you've eaten in Vancouver now?
I'm a big ice cream fan, even though I'm lactose intolerant. I just suck it up. And I
Mhm.
am 300 meters from this place called Ernest Ice Cream, and it has
Okay.
been dangerous, but it is so good. And they
Nice.
change their flavors every month,
Okay.
and it is phenomenal. So that's probably been
Awesome.
my new go-to. And I
I love
also
it.
just love the coffee scene here is amazing.
Yeah, it was good. I'm
Yeah,
not gonna lie.
yeah,
And then Shalea Kip told me to get ramen. And so
yes,
when an Olympian tells you to go get ramen in some strange new city, you go do that. So that's
yes.
what I did, and it was awesome.
Yeah, the
Cool.
food scene here is pretty
It's
cool.
really good.
Yeah,
It's really good.
yeah.
All right. Who's somebody in your space that we should know about? Who are you loving right now?
Yeah, I think I have a lot of mentors, and I've been very lucky to be mentored by a lot of awesome, strong, powerful women. I would say coming off of a postdoc with Jane has been
Yes,
phenomenal. So Jane Thornton is now the director of the Medicine, Science, and Health Department at the IOC. She's the first woman in that position.
I know it's amazing.
She is just like a total badass.
Yes.
She is the smartest person, one of the smartest people I've ever met. She's also
Yep.
one of the kindest human beings, very supportive. And I think without her, I would not be in this space and be where I am
Yeah.
today without her support. Um,
Yeah.
and she has given me plenty of opportunities, lots of opportunities to be able to talk and promote myself and promote my research.
Yeah.
And now she's making massive changes to the sport organization as a whole. So she is someone that I admire and will
Yeah.
continue to admire, and I'm lucky that I get to call her a colleague and a friend. So
Yeah.
yeah,
No, that's amazing. I wholeheartedly agree with that one. Amazing.
yeah,
Awesome. All right. If you guys want to know more about Jenna, Vancouver, running, doing 2 postdocs and Vancouver, you can find her over on Instagram. the.rungry.researcher. Jenna Schulz, thank you so much for finally having this conversation. And we're so excited for what's to come in the research in the future. Thanks for joining us.
Awesome. Thank you so much for having me.
If you're navigating pregnancy, postpartum, or perimenopause, whether personally or professionally, check out all our free resources and upcoming courses at carriepagliano.com. This podcast reflects the opinions of Dr. Carrie Pagliano and her guests, and it is for entertainment purposes only and should not be considered medical advice. Always consult your healthcare provider with any medical questions. If you enjoyed the episode, please take a moment to leave us a 5-star review on your favorite podcast platform. And thanks for listening.